Good morning, everybody, and welcome to the March 2025 version of IIDR Rounds. I'm Lori Burrows. I'm the Associate Director of the IIDR. I'm very excited today because we have both the newest and the original member of the IIDR presenting. So the first presenter is Dr. Brody Duncan. He is a medical microbiologist, infectious disease physician, and an assistant professor in the Department of Pathology and Molecular Medicine. He is also the program director for McMaster's Medical Microbiology Residency Program. His research interests center around using bioinformatics tools to predict antimicrobial resistance, and today he'll be discussing the use of population-level antibiogram data for choosing empiric antibiotics. Our second speaker today is Dr. Gerry Wright, who is a distinguished university professor in the Department of Biochemistry and Biomedical Sciences and the founding director of the IIDR. This past year, Gerry received the very prestigious Killam Prize in Health Sciences for his critical research into antimicrobial drug discovery and antimicrobial resistance. And today he's going to be discussing a bait capture platform that allows researchers to selectively enrich and characterize AMR genes in complex metagenomes. So I am looking forward to your talks. If you have questions, we actually have now the opportunity to unmute people so they can actually ask a question. So raise your hand at the end and I will try to address the questions. And now I'm going to turn it over to Brody.
That's wonderful. Thank you so much for the kind introduction, Lori. Perfect. Okay. All right. So we will get started. So again, thank you for the introduction. My name is Brody Duncan. I'm a medical microbiologist and infectious disease physician here. So today I wanted to talk about using population-level antibiogram data for choosing empiric antibiotics. I acknowledge that this is not necessarily like the sexiest, like cutting edge research topic, but I think it's very interesting. I could talk for like hours and hours about this, but I will purposely try and hold myself back to just some things that I think are useful both for the clinical people in the audience, and I think also will give some insights to some of the primary research scientists about kind of how this decision is made on a personal and institutional. So I'll start with a very simple case. So let's say we have a previously healthy 31-year-old woman who comes to the emergency department because she's got a 4-day history of typical bladder infection symptoms like burning when she pees, having to pee all the time, having this urgency. She wasn't able to make it to see her family doctor because of life reasons. And now she's actually feeling quite a bit sicker. She's feeling feverish and nauseous. She's worried it might be going up her kidney. So then when you examine her, you find she does have a fever. She does look kind of a little bit sick and very tired. And when you tap on her right flank, it is tender. So to me, like this is very typical textbook pyelonephritis, which is exactly as what she thinks it is, a kidney infection, which usually starts as, a typical community-acquired E. coli bladder infection and then spreads up. And most cases of UTI are caused by E. coli, like that is true around the world and especially in Canada for our, otherwise healthy people out in the community. However, it usually takes a day or two for us to confirm the antibiotic resistance profile of a urine culture because we have to wait for it to grow and then we have to wait for the susceptibility test, that sort of thing. So then, the question from a clinical point of view is what empiric antibiotic do you prescribe to treat your UTI while you wait for those culture results to then decide like the definitive, definitely. So, this is not as easy a question as one might originally think because your run-of-the-mill E. coli is susceptible to many different antibiotics. I'm not going to read all of these out, but you can see there's like 10 million different beta-lactam agents that can treat E. coli infections. And there's a ton of different other classes of antibiotics, and often inside of those classes, there's multiple agents, right? So, right away, I'll say there are some of these that we wouldn't choose for patient safety. For example, some of these, especially some of the older drugs, have too high rate of side effects. So I would say, yes, it'll work, but the risk is probably higher than we would want it to be. So we can cross those off the list. And then there's also quite a few of these that have poor clinical efficacy for the type of infection. For example, some of these, I would say, yes, it might treat the bacteria in the petri dish, but in a patient with a real kidney infection, especially if they're getting a bit sick, like I know that it doesn't quite get the job done. So we can cross those off the list too. But there's still lots of choices among the rest. So the question still remains, like, how do we actually choose something, right? And you'd think surely they taught us the answer to such a common question in medical school, right? But it's a little bit more complicated than you would think. And again, this goes to, I often have medical students even now still rotate with me and patients like this present. And they list off, oh, a bunch of different options. And I say, okay, that's great to have options, but we have one single patient who's right here in front of us, and we have to pick one. So how are we going to pick one antibiotic? So if you went to medical school in 1999, that's when the IDSA put out this guideline on treatment of patients very similar to the case I'm presenting here. And here they do give this very clear recommendation for empirical therapy. We recommend an oral fluoroquine, and they're making a pretty good recommendation there. And they do give oral trimethoprim sulfamethoxazole as an alternative. So that seems very straightforward, right? You would say we've got a list of antibiotics. We'll put oral fluoroquinolones at the top of the list for a patient not too different from this one. However, if we were to be in medical school 10 years later in 2010, we can see that the language in this IDSA guideline is now saying oral Cipro is an appropriate choice for therapy in patients not requiring hospitalization where the prevalence of resistance to community uropathogens to fluoroquinolones is not known to exceed 10%. And they also have like a very strong recommendation behind that. And then they say your alternative agents could be like a ceftriaxone or glycoside, depending how sick they are. So here you can see that there's a bit of nuance here, right? Like they still have fluoroquinolones at the top of their list for patients similar to this, but there's this caveat. It's not just straight use ciprofloxacin. It's you can use ciprofloxacin if you have this background data on resistance. And then very hot off the presses, just in February, it's actually not even on the presses. There's this IDSA guideline on the management and treatment of complicated UTIs, which is not actually formally published. They have the final draft available to the public, and they're asking for public comments, where they have this new table where they have a more strict stratification of the condition of the patient, and then inside of our preferred antibiotics you can see there's lots of different choices, and they're not really ordered. So for example, for this patient, if we want an IV, now we could use cephalosporins or tazofluoroquinolones, or if we wanted to do oral, we could do fluoroquinolones or oral cephalosporins, and then we also have even more. And to make this even more complicated, now these proposed guidelines are advocating this four-step approach where, we look at the severity of illness, we evaluate individual risk factors for resistant organisms, patient-specific factors, and then for our sicker patients, also looking at an antibiogram with this 90% susceptible threshold. So again, I would say that compared to 20 or 30 years ago, it's not so simple as, oh, fluoroquinolones are my favorite antibiotics, like that. Now it's like we have to take all these different features into account, and still sometimes it can be a little bit person. So, with all of that background information, the purpose of today's talk is not to talk about the treatment of UTIs, because that's obviously very complicated, but I want to talk about the fact that as antibiotic resistance spreads, knowing your local resistance patterns is important. And this is especially true for the sickest patients, like those with septic shock, where 1 to 2 days of ineffective empiric antibiotic treatment actually could contribute to mortality, right? You could start them on ciprofloxacin, and then by the time you get the result that it's ciprofloxacin 48 hours later, the patient could be. We also, can take that into the second point, which is really the primary focus here, which is that cumulative antibiograms are the most accessible tool for trying to understand these population-level resistance patterns locally and. So to talk about cumulative antibiograms, they're very simple tools. But for doctors, anything that involves numbers is sometimes a little complicated. So we try not to get more complicated than this right now. So with antibiograms, really, we count all the patients that had culture-confirmed infections over a period of time, which is usually 1 year. And then we look at those bacteria and we count how many of those bacteria were susceptible to each antibiotic, and then we put it in a table. And you can see that on the right here. This is 2021 national antibiogram for E. coli, where again, they just have a whole bunch of different antibiotics and they polled a bunch of different laboratories across the country, and then they put that into. This is something that any elementary student could calculate, right? In terms of some general principles, I could talk about this in a lot more detail, but I think some key things for you guys to know today is that, first of all, local data is more applicable to your patient. I think that makes a lot of sense, that national data doesn't necessarily reflect what's actually happening locally here in Hamilton because it's averaged out across the country. It's also important to only count real clinical samples from real patients. So, some laboratories could accidentally include research isolates. They could accidentally include surveillance swabs where, for example, you're swabbing patients' noses to see if they're colonized with MRSA. So we don't look at those. We only look at patients that have real infections. And we also try not to double count patients. So, if a patient shows up with an E. coli UTI in January and then they get it 2 or 3 more times later in the year, we don't want to overrepresent that patient. So we usually just pick the first isolate the first time during the time period. So this all seems very straightforward, right? Like it's just simple proportions. And at the end of the day, the actual production of it is just data wrangling. Here I'm presenting an example of a hospital cumulative antibiogram, which is actually our hospital antibiogram for Hamilton General Hospital. You're getting a sneak peek at our 2024 data for the past calendar year, which I am in the process of formally putting together and will be published probably by the end of this month for all the clinicians to have access to. So here you can see that we have all specimens excluding surveillance with the percent susceptibility. We have a number, this is just for gram negatives. We have a number of different bacteria with, lots of isolates for each one of these. We have a bunch of different antibiotics that we're reporting here. You can see that susceptibilities really do vary across organisms and across antibiotics. We have gray boxes for antibiotic bug drug combinations that we really don't want people to be using, often because of intrinsic resistance. And then there's a few where just because of the way our lab is set up, we have. But this is what it is. It's not complicated. So I think to circle back to our case, like I can look at this data and say, if this patient was being seen at Hamilton General Hospital from this cumulative antibiogram, I would probably not use a fluoroquine empirically, because you can see that here our Cipro rate for E. coli is 63%, which means that, if you have 3 patients that you give ciprofloxacin to, one of them is very likely to end up being resistant. So that's a 1 in 3 probable failure rate. Another point is that depending on how sick she actually is when you see her, I would be very careful about ceftriaxone empirically. For many years, ceftriaxone has been one of our go-tos for these patients. But if she was really sick and I didn't want to have like even a day or two of potentially ineffective treatment, we can see that ceftriaxone here doesn't really hit whatever, mark you might have in your head. 80%, 1 in every 5 patients having a failure, that's something where some doctors would say, I feel a little risky about that. And then one thing that's reassuring from our data is that if she was very sick, we can look at piperacillin tazobactam or a few other options and say that piperacillin tazobactam meets our arbitrary 90% threshold to say, even if this patient was very, very sick, I can feel confident if I prescribe piptazo that statistically I would expect it. So that's a cumulative antibiogram and how I think a lot of doctors on a very superficial level would interpret it. We'll get into now a few additional points, which is that we really have to be very thoughtful when applying cumulative antibiogram data to patient care. And this is something that for me, it's not a major research focus of mine, but it's something over the years I've spent a lot of time thinking about and talking with colleagues about to figure out how can we really take this extensive data we have in the microbiology lab and help provide it or not provide it to clinicians to help, improve the way that we prescribe the antibiotics empirically. So we'll start with this first question, which is, does my patient belong to the population being described in the antibiogram? So here I have copied some data that is publicly available from Life Labs, which is one of our major community-based laboratories in Ontario. On the top, we have data from their outpatient walk-in antibiogram, which is patients who are otherwise healthy, usually go to their family doctor, they get an order to go to the Life Labs, they pee in a cup, and then this. On the bottom, we have Life Labs also does a lot of work for long-term care facilities. So this is patients that often have a lot of comorbidities or a lot older, often not mobile, higher risk, more complicated UTIs. And they publish that data separately because Life Lab says really these are 2 different patient populations and we don't want to conflate them. And we can see comparing these data that there does seem to be significant differences between these. If we look at the 20,000 E. coli's that Life Labs had in 2023 for outpatient walk-ins, the ceftriaxone rate is 92%, while in the long-term care facilities it was 78%. And similarly, looking at ciprofloxacin, you can see that some doctors for some outpatients, depending on patient factors, might be able to get away with ciprofloxacin, right? While in our long-term care facility, ciprofloxacin really is a bit more of a coin flip in terms of if it's going to work. And I think this is a nuance that a lot of people don't necessarily appreciate is, if you are a family doctor treating an otherwise healthy person who's just coming in with a bit of burning when they pee, You can't necessarily look at our hospital antibiogram to guide your data. And similarly, if you work in a nursing home, you don't want to be looking at your otherwise healthy outpatient walk-ins when you're deciding antibiotics. So this is one of those baseline things that can be very easy to miss the nuance. Another thing is, a lot of people are trying to get into the nitty gritty a little bit more and say, okay, we've got data for the entire hospital, which I'm presenting here on the top, but we can also actually look at ward level data. And so here on the bottom, I'm presenting data for the past year for just our ICUs here in Hamilton. And if we focus in on a few key things, we can see that if we look at ceftriaxone and piperacillin tazobactam, there's actually really significant decreased susceptibility rates to these beta-lactam agents in our ICUs compared to the hospital as a whole. And again, I think this is really helpful information because in terms of the patients, even if you're physically in the same building, and it might even be the same sort of patient, if one of them you see in the emergency department, you say, okay, this person's a little bit sick, we'll admit them for a couple of days, but they'll probably go home. You might treat that patient a bit differently than a patient who's in your ICU, has multiple organ failure, has the same sort of infection, but is much sicker and in a different setting, right? And this is something that over the years, me and my colleagues have talked with the ICU about in terms of, a lot of us feel that there's a lot more resistance in our ICU compared to the rest of the hospital. And these are the sorts of information the lab can provide to kind of justify that feeling and actually provide empirical data to guide empiric treatment. Finally, I'll talk a little bit about the importance of up-to-date antibiograms. So here on the top, we have data from Hamilton General Hospital from this past year. And on the bottom, we have the same data from 2014, just 10 years ago. And you can see that there are significant differences, again, where over the course of 10 years, we have seen that antibiotics, which are very, very important, like ceftriaxone, have gone from 91% susceptibility on the cumulative level to 80%. And I think this matches up with a lot of our clinical experience that it used to be that ceftriaxone really could be our go-to beta-lactam. Most patients would be treated perfectly effectively. And over the course of years, we've really seen that slip significantly. And I think that this is one of those things where a lot of doctors on an individual level notice these sorts of trends happening. And it's only when we actually calculate these antibiograms that we can kind of go out in public and say, it's not just you noticing this on a whole population level, we are seeing these differences. Similarly, if we look at ciprofloxacin, it wasn't great 10 years ago, but it wasn't awful. And we do have data going back even 10 years before that, and it was even better then. So this is where, again, like over time, it's so complicated to know which antibiotics to use for which patients. And if you don't have the most up-to-date antibiograms, you might, even be working off of erroneous data. So most people try and update their antibiograms at least once a year because of this sort of issue. So that's kind of the focus I want to talk about in terms of population. The next question, which I think is maybe a bit more interesting, is the data in the antibiogram actually useful for answering my clinical question? So if we go back to our case and we say that our patient shows up and you examine her and you're like, oh, she's actually very sick, like going into septic shock, she might be going towards the ICU. And, your medical student that's with you says, oh, there is a decent ESBL rate in these sorts of patients. I'm worried if we use ceftriaxone that we could be mistreating an ESBL producing E. coli, right? And again, only 80% of our E. coli are ceftriaxone susceptible. So the question which a lot of doctors really, do ask is, does double coverage, for example, using ceftriaxone with ciprofloxacin, help increase the likelihood of treatment? And this is where, some people would look at this data and say, oh, we can, use math and we can combine the probabilities of ceftriaxone with ciprofloxacin to say, it is going to increase the likelihood of treatment success. So if we want to avoid using a carbapenem or something, we could probably do that. However, that actually would be the incorrect answer because these are not independent probabilities. So this is why it's important for labs to try and look into their data and see if we can give these enhanced antibiograms that don't just give like simple counts, but also kind of get into that nitty gritty. Because you can see here that this is work that I'm working on formalizing again, so that this is a new offering that our antibiograms can give for our hospitals. We have E. coli on top, and then a subset of E. coli that have ESBL as the second row. And you can see that if we look at our ciprofloxacin column, almost none of our ESBL E. coli are ciprofloxacin susceptible. And this is because ESBL E. coli are highly likely to be multi-drug resistant. They are not independent probabilities. Often these bacteria, as they gain one resistance mechanism, lots of other ones come with it too. So, with this empirical data, we can see that carbapenems as a single agent give much better coverage than a combination of ceftriaxone and fluoroquine. And I think that that's actually clinically relevant. I think a lot of the physicians on this call can think of times that they have seen other people say, oh, I'm worried about ESBL, let me add on ciprofloxacin just in case. And I think this empirical data really does tell us we probably should not be doing that, and that's probably the wrong thing to do for the patient. I'll also take a very brief note here that most antibiograms are not able to give data on the genetic mechanism of resistance, right? Some labs don't even test for ESBL. So this is something that I think over the next 5, 10, 20 years, as our labs get more diagnostic capacities, we'll hopefully be able to update our antibiograms to be able to give this more sort of niche mechanism-based data. In terms of a similar clinical question to that, if we have a patient who has a previous history of ESBL E. coli UTIs, and then let's say they show up to hospital again a year later and they have another episode of pyelonephritis, should we use the antibiogram to guide our empiric coverage when we're seeing this patient? And the answer here is generally no. There's not great data for this. Here on the right, I have a table from a review that in that new IDSA proposed guideline they have. Really, it seems as if prior culture results are a better predictor for an individual patient than population level statistics. And again, here in this table, they have a bunch of different odds ratios. It's not perfect prediction, but in general, if a patient is known to have an ESBL E. coli in the past, or is known to have a fluoroquinolone resistant E. coli in the past, that's probably the more important thing to look at than looking at just your general population, right? However, it's difficult to say how far back to look, and it's difficult to operationalize this in a strictly accurate sense. I think all of us as physicians have seen patients where 1 month they have one resistance profile, and then 6 months later they show up and they've got something totally different, right? And here in these studies, even there's no consistency in terms of the time interval between cultures, but some of them looking up to 6 years in the past, and some of them only looking 1 year in the past. And that's a question I get from pharmacists and students and stuff all the time is how far back should we be looking? And I say I don't know, you just kind of have to listen to your gut, right? So I think that those are some important nuances. And along with that, I think a third really important question is, do I understand the underlying limitations of antibiograms? So, what about small numbers of isolates? There's lots of bacteria that you only find a couple of handfuls of times in a given year. So can we still use antibiogram data to be useful for those sorts of bacteria? And the issue here is that antibiograms are presented as point estimates of susceptibility. There's no error bars, there's no confidence intervals. Even if you put confidence intervals, I think a lot of medical professionals are not as statistically inclined and wouldn't necessarily know what to do. So because of that, the general recommendation is we want to have an N of at least 30, which is a generalized cutoff to avoid large year-to-year variation. And here on the right, I have a chart from a paper that tried to get some modeling and empirical data to support that recommendation. And you can see that, when we have isolates with numbers of 30 or more, we see that there is going to be some year-to-year variation in susceptibilities, but it's usually, less than 5 or 10%. While when we have less than 30 isolates in a given year, we see that for some bacteria, it still stays quite consistent, but for other ones, there's humongous variation year to year, right? If you only have one of some obscure bacteria in a year, it's just whatever that one patient happened to have, right? That's not helpful population level. And again, this is something that some laboratories do not stick with, and I do think it potentially is putting patients at risk to misinterpret. Another question is, how low is too low? What percent susceptibility is acceptable? Is it more than 95%? Is it in that 80 to 90% range? Is it more than 75%? Is it less than that? And what does acceptable even mean, right? Different patients, the word acceptable might mean different stuff, right? Treatment failure is life or death in the patient with septic shock. But for most simple infections, there's usually not a long-term impact to a 1 or 2 delay in effective antibiotic therapy, right? So I think this is where, in terms of acceptability, we do see that the pendulum swings different ways depending on who you're talking to, where some patients looking at, or some doctors look at an antibiogram and say, oh, I want to make sure I'm picking the best number to ensure that my patient is getting the best possible therapy. While other doctors will say, okay, the number's not perfect, but there's lots of other side effects. Antimicrobial stewardship is important, so I might accept a lower number, acknowledging all of these different risk benefit decisions. So I certainly don't have an answer to that today. I don't think anyone has an answer. Every guideline just picks a number and sticks with it. One thing I will say is color coding is my pet peeve. I hate looking at antibiograms with color coding. And the reason for that is that the arbitrary cutoff numbers for color coding is totally arbitrary. Even just as I was preparing this talk, I looked at local antibiograms from, Ontario and Canada, where this one, for example, had a susceptibility rate of less than 60% getting the red color. I've also seen ones where 80% gets a red color. And I even saw one where 20% got the red color. So between 20 and 80, it was still colored yellow. So I hate this because I think it takes away a lot of the nuance that we're talking about between, septic shock versus simple bladder infection. And it just goes to your monkey brain of saying, okay, red is bad, so we'll avoid red, right? So don't show me an antibiogram with color coding. I don't want to. And then after my little rant about color coding, the last thing I really want to present is this question of like, do antibiograms actually improve, right? And, this is a bit of an unfortunate truth is that we don't have good clinical evidence that antibiograms actually change important patient outcomes. It feels like it should, and it feels important. And there's certainly lots of retrospective data that modeling suggests that using an antibiogram would help doctors to make good decisions for their patients. But there isn't actually good clinical evidence that, again, looking at these numbers and making little decisions based off of, 5 or 10% differences actually changes patient outcomes. So because of that, we really do have to be very cautious when using population level statistics for individual patient care, right? Individuals are not statistics, they're individuals. And I think, for example, that new IDSA urinary tract infection guideline kind of does get to that point that antibiograms are probably one of the less important of all of the things we keep in mind as we choose antibiotics for our patients. Final point here is that, some people argue that maybe they're better used to develop institutional guidelines rather than guide individual physician decisions. And I think that there is some merit to this, which is, we see that over the course of 10 to 20 years, resistance profiles change. Is it more helpful for us as an institution to just present that as a general feature as opposed to giving this niche bug drug, point estimates of susceptibility, which again, some people might misinterpret for certain patients? I don't know. So that's my presentation. The takeaways here is that antibiograms are necessary to understand and compare local antibiotic resistance patterns. Antibiograms are probably useful to guide treatment decisions when there isn't other data available, but there's limited evidence for that. And statistics do not directly apply to individuals, so you do have to be very careful with those limitations. In terms of future direction, so some people say, complex prediction models may be more helpful for individual patients. And honestly, for me, I think the more likely future direction is that faster susceptibility testing, such as molecular or even one-day, sequencing, is going to become more important to help guide those first 24-hour antibiotic prescribing choices as opposed to just diagrams. So that's my presentation, and thank you very much.
Thank you so much. Great segue to Gerry's presentation. Speaking of molecular testing.
Okay, I totally agree. So thanks, Brody. I think you teed this talk up quite nicely. And what I want to tell you about is some work that we've done over the last several years in collaboration with Andrew MacArthur's lab and Hendrik Poinar's team to develop these molecular tools, not only of the future, but I think we can also put them to use, especially as we're trying to understand population level resistance in complex metagenomes, whether they're environmental or whether they're in individuals, as I hope to be able to show you. Okay, so many of you are well aware of this. This is the Comprehensive Antibiotic Resistance Database, front page. If you don't know it, you should. It's a real gem put together by Andrew and his team here at the IIDR. What I want you to narrow in on is that there's a lot of molecular data in the database. There's well over 6,000 reference sequences of antibiotic resistance genes. There's close to 5,000 SNPs associated with resistance. So we have a really good curated understanding of the molecular basis of resistance. And the question is how do we leverage this information in trying to understand the levels of individual resistance genes in complex populations? And so, the question is, how do we measure the resistance? Well, whether you're coming from an infection or from a microbiome sample, the traditional way, as Brody was just discussing, is that you culture and then you do an antibiogram, and that takes a while, and that's one bug at a time usually. But we know that if you're trying to understand the population level of genes, that there's probably better ways to do this in this modern age. And so those included, 20 years ago, PCR amplification of individual genes for molecular testing. I remember quite distinctly when we tried to introduce the vancomycin resistance gene PCR tools back, I think, in 1994 or 95 in the clinical lab, and that was a big change of things. But now we're moving into really cheap next gen sequencing, and what I'm going to tell you about today is really probe-based methods, that I think are going to be the future for this kind of work. So metagenomics is great, but very inefficient. So if you want to get an understanding of all the genes in a metagenome, let's say it's a gut sample or even a sample from an infection site, you're going to get mostly DNA that is not what you're interested in. You're going to get either host DNA or other microbes or the other genes on the microbes that you really don't care about if you're interested in AMR. So Alison Guitor was a PhD student in my lab several years ago, and then working with these nefarious dudes here, we came up with this application of technology that Hendrik and company and the ancient DNA guys had developed, which is really how do you get the sort of needle in a haystack as you're trying to identify the genes that you're interested in and discard what I would call contaminating genes, right? And so most of the time, the genes that you're interested in are let's say they're 1% and the non-target genes are 99%. So the idea behind this capture protocol is you get your DNA, you get your metagenomic DNA, you develop a series of probes. In this case, they're RNA probes that you link to a biotin bead, hybridize within your metagenome, capture these on very simple strip-avidin encoded magnetic beads, sequence, and now the idea is to map these down to card. And now what you've done is really enriched your sample for the genes that you are interested in. So that was the idea starting out. We challenged Alison to be able to develop this technology for antibiotic resistance, and I'm delighted to tell you that it was quite successful. So here's an example of some of the first work that she did using a gut metagenome sample, comparing directly to shotgun metagenomics. We are looking for AMR genes. We find that they're much less than 0.1% of the total amount of DNA that we sequence. So think about your pocketbook, and if you're in a clinical lab, if you're doing metagenomics in the future, as Brody was saying, you really would be sequencing a lot, spending a lot of money on sequencing and not getting what you're really looking for. On the other hand, using these probes, we're enriched to the point where the sequencing that you were doing is pretty much 50% of what you've sequenced is exactly what you've been hoping to get. In this case, antibiotic resistance genes. And of course, just parenthetically, this technology you can adapt to anything, right? As long as you have the probe set that you want, you will be able to identify the specific genetic elements out of complex metagenomes. And in fact, that's exactly kind of the work that Hendrik's team is doing to try and, for example, enrich for DNA of infectious organisms in ancient samples. So here's an example of what we did, a nice little collaboration with the team in that was headed up by Eileen Hutton, Kathy Morrison, and Jen Stearns, with their graduate student Efra Youssef. They had developed a little cohort study where they were trying to understand whether or not the premature infants in our NICU, if it was worthwhile to give them probiotics. So the babies in a NICU are all given antibiotics. So here's a patient population that right from the get-go will be hit with antibiotics. They're also in the hospital, right? And so their first encounter with the environmental microbiome is mostly pathogenic bacteria that are in our NICU environment, right? So the idea is that if we could give them probiotics, would this decrease the amount of terrible infections like necrotizing enterocolitis, and could we actually promote healthy gut microbiome development? So that was the goal behind the initial cohort study. And what we did is said, well, can we actually interrogate these samples from these infants, which are stool samples, for resistance? And does exposure to probiotics lessen the resistant prevalence of resistance genes? So that was our hypothesis. So, we had a series of within that cohort, we had some babies who did not get probiotics. We got babies who did get probiotics, and then we compared those to full-term infants, so not people who are individuals who were not in the NICU, and then we got samples from them 10 days after birth. So here's the results using so we went in, Allison received stool samples from all these individuals in this cohort. We used our probe-based approach to look for resistance elements. And here's what we found. And the caveat here is that this is a very small sample size, but it's encouraging to me, right? So this is the y-axis here is a number of unique antibiotic resistance genes per infant. And you can see that the preemies who did not get probiotics have a pretty high burden of resistance elements in their gut microbiomes, whereas the babies who did get probiotics, that number was significantly reduced, even compared to full-term infants who were sampled 10 days after birth. So this is very interesting to me. The resistance genes that we got were the ones that you would predict to be floating around in a hospital: aminoglycoside resistance elements, beta-lactamases, tetracycline resistance, sulfonamide resistance, all these very classically associated with mobile genetic elements like plasmids and integrons within them. So this is not surprising. So again, you just look at the numbers here. There's no probiotics. There's a lot of diversity of resistance genes in babies with probiotics, not so much, and then even less than full-term infants. We looked at this longitudinally as well. So once they were in the hospital, these are in the case of non-probiotic supplemented babies. This is what we got in the hospital, and we were looking to see, does this wash out over the next 5 months? And the answer is pretty much no. And you can again compare it to the probiotic supplemented in babies, and you have a lot more white space here. So I thought that was very interesting. The probiotics did seem to reduce the diversity of these AMR resistance genes up to 5 months. So the conclusion from this study, and again, it wasn't designed to look at this, was that probiotics does, at least in this cohort, reduce the diversity of resistance genes in these preterm infants, and that lasts for at least 5 months. I can't tell you at all if that matters. So we didn't have any metadata to figure out whether or not these babies were infected later on, if there was any other complications, does this in fact have a negative side effect or not. But I think it's an intriguing initial data point to follow up on. So in the next study where we've applied this work is many of you on this call, I'm sure, are well aware that there's a massive effort to reduce childhood mortality, in particular in sub-Saharan Africa, because of all these diseases of childhood, malaria, diarrhea, in particular, respiratory tract infections. And there's been an effort to use mass application of azithromycin prophylactically as an intervention. And this actually works. So in large population studies, we are seeing that prophylactic provision of azithromycin is having a significant effect on childhood mortality. But the big concern has always been, are we going to pay the price for this later on, because resistance is going to be a real challenge? Because we're using an antibiotic, you're going to select for resistance. So there's several ongoing studies in a number of countries. One of these actually did look at antibiotic resistance, and what they found was that there was an increase in resistance. That's not surprising to anyone who works with antibiotic resistance. If you use the antibiotics, you select for resistance. But what they found is that longitudinally is that it was very specific to the area, and it plateaus after a couple of years. It doesn't continue to increase over time. So that's a positive thing. And I think if you're thinking about risk benefits, about the application of these kinds of treatments, at least at first glance, we don't know what this means later on 10 years from now, that azithromycin treatment is not necessarily a bad thing, because you can live with the knock-on effects of resistance. So we got interested in a study that was ongoing from some IDR members, so Jeff Pernica and David Goldfarb, who had developed an RCT in Botswana with children with acute non-bloody diarrheal disease. And the idea here was, can we do a rapid diagnostic to decide if these children have either E. coli, Shigella, or CAMPI, and if we see this using this rapid diagnostic, then we will treat with azithromycin for 3 days and see if something happens. And the standard of care is that you don't get a diagnostic and you don't get azithromycin. So we brought, so the hypothesis here again was that if you give azithromycin, you're going to have increased macrolide resistance. And we have exactly the tools to be able, with our bait capture method, to test that. But we were surprised. So what we found is that whether you're in standard of care at baseline, so day one, or whether you're in a rapid test and treat pool, there's a lot of resistance genes out there already. And if you look at 60 days later, it doesn't really change. So that's interesting. So this is overall antibiotic resistance genes. You're not increasing overall because there's a fairly significant amount of resistance to begin with. So if you so you say, all right, so that's overall resistance. What about macrolide resistance, which is what our hypothesis was that we were going to have an increase in this. And so hopefully you can see this. There's a line here on the left-hand side. These are all antibiotic or macrolide resistance genes, or azithromycin resistance genes that are found in CARD and in our bait set. There's the rapid test and treat on the left-hand side, standard of care on the right. This is at baseline. You can see that there's already lots of macrolide resistance. And after 60 days, there's no change. No statistically significant changes you can see across here. Again, these are all these resistance genes going up and down. So there's not a significant amount of impact of giving azithromycin to these children. So the conclusion from this study then, even though we found lots and lots, these are just tables and tables of all the different resistance genes that exist out there, the burden of AMR genes at baseline in this cohort was already so high that if you treat them with azithromycin like this, it didn't matter. So it really does emphasize the cohorts that you were looking at in your starting environments and just how impactful that is. We saw that with the premature baby cohort and also with this one as well. But this is now the actual molecular data to be able to go in and show this. So we're pretty excited about that. And then just finally, I want to show you where this is going. So this is now something, a project that was funded by the David Braley Center. We're very proud of that. Again, this is my partners in crime on this. This is Dirk Hackenberger, a PhD student who we supervise, and Dirk came up with this really interesting tool that he calls CARPDM, called the Comprehensive Antibiotic Resistance Probe Design Machine. And basically what this is an informatics tool that is now embedded in CARD and will design probes as CARD expands sort of automatically, so that you're not having to go in and as CARD adds more and more genes. When we started this study with Allison, I think there was 2,500 genes in CARD, and now there's north of 6,000. So, you don't want to go back and have to continually redesign probes. And the really cool thing that Dirk did as well is he built out a very cost-effective probe design and synthesis system that you can actually do in the lab, right? So in the previous studies, we had hired a commercial company to be able to custom make these probes across all these resistance genes. We can now do this in-house at much reduced cost that I think actually makes it really possible to use these kinds of molecular tools to go out and explore a lot of different metagenomes, whether they're in the environment or not. So here's an example. This just was published in Applied Environmental Microbiology 2 weeks ago. And our in-house, or when I say our, I mean Dirk's in-house baits, really outperform the commercial ones. This is now, so we're looking at wastewater. So thank you, Lori, for getting us connected to this from Hamilton. Over two days, the green dots are when we make probes to all of CAR, all the resistance genes in CARD. The brown dots are when we just take a subset of about 350 that are probably that we assess are more clinically relevant. And the purple dots are our in-house probes, and the pink are the commercial ones. And we outperform always the commercial probes with Dirk's probes outperform them. The interesting thing here in wastewater is what you're finding is that if you want to look at the resistance genes in wastewater, they're probably all coming from just people. Here, just that small subset of probes, about 350 that we call clinical CARD, is perfectly fine. Whereas if you're looking at various soils, and Dirk looked at the three different that he called low impact, high, medium, and high. The high impact soil was actually the smokers region out here in front of Mumsy. The low impact was up in the Northwest Territories, and medium was Cootes Paradise. And you can see that when you're looking at a more diverse microbiome and a more diverse metagenome, using all the genes in CARDs makes more sense, which is more expensive, obviously, but certainly you have to know what you're looking for. So I'll finish there. I think what I hope that I showed you is that what these DNA-based measures of resistance diversity is much more superior to traditional culture if you're trying to understand what is the diversity of antibiotic resistance genes. But because AMR genes represent such a small fraction of the genes in metagenomes, you have to use tools like these bait capture approaches to be able to and make sure that you're looking at a haystack that is small enough to make sense of. And I'm really excited that we can apply this to all sorts of applications, whether they're cohort studies, as we showed you, or RTCs, or just general surveys of the environment. And in fact, Dirk is in process of starting a company to be able to do this for wastewater samples from a number of different places. So I'll stop there. I do want to thank, again, the Braley Center for funding, in particular, Dirk's project. And I'll turn it over to you, Laurie, to address whether or not there's questions.
Thank you, Gerry, very much. Okay, we have a couple of questions. I'm going to ask if you want to unmute yourself to ask your questions. So Manoj, you have a question for Brody?
Okay. Hi, Brody. Thanks for the great talk. So my question is, the resistance in E. coli and K. pneumoniae, like in Canada, seems rare, maybe like less than 5 to 10% of the isolates are resistant. And moreover, like these resistant strains, they may be susceptible to other antibiotics. So do we need like new antibiotics in Canada, or is there a scope for new agents in Canada?
Thank you so much for that question. I think that's actually a really important question and something we definitely struggle with, both locally and I think on an international level when it comes to new antibiotics. The issue is that if we look at, for example, meropenem, on a population level, 99.9% of our E. coli isolates are meropenem susceptible. So the amount of meropenem resistance is like a rounding error, negligible. However, for those patients that are that, 0.1% that have meropenem resistance, like that is often critical and sometimes life-threatening. And we have had patients die from those infections because we don't have access to antibiotics, right? So I think that's a really, really great question to point out the discrepancy between population level, antibiotic stewardship decision making and individual patient care is that even though generally, like I would never use a novel agent like ceftazine avibactam empirically for populations, if we have individual patients where we know that they have these like very specific and high risk antimicrobial resistance genes, that's really the target where we need new antibiotics. And it's because we don't have anything else we can turn to. So even though it's very expensive, it's a lot of work for everybody. There's all these like political and pharmaceutical complications with getting new antibiotics. Like that's the sort of thing where today it's 0.1%. 10 years it might be, 10%, and at some point it might be the majority, right? So I do think that we shouldn't accidentally use cumulative antibiograms to diminish the importance of some of these emerging high risk antibiotic resistance genes.
Thank you.
Great, thank you.
Thank you.
Yamin has a question. Yamin, I don't see online, so I'll just read the question. Thanks, Brody, for the antibiogram. If the patient had repeated confirmed lab culture, can I add it to the antibiogram or only once? Can the program do it, or is it available to be added manually?
That is also a really good question. So the party line is usually if patients have repeated, prior cultures, we don't include it because for that individual patient, the antibiogram data actually isn't helpful anymore. It's better to look at their particular isolates. I'll say there has been a small amount of research into this specific question where, for example, in our ICUs, we do have issues with patients getting, Pseudomonas infections multiple times, where, at first it's susceptible to everything, then you give them Piptazo, and then the next one's Ptazo resistant, et cetera, over the course of weeks. So there has been some research into if you can create models that can predict what future isolates are going to become resistant to, but it's still all very like investigational. I don't think any of them are really validated for use in a clinical setting yet.
Okay. Merrick, you have a question? I can try to unmute you. Unless you can unmute yourself. Oh, there we go. Merrick, go ahead.
Sure. This question's largely for Gerry. So we're still a long way away from, clinically applying routine sequencing for resistance testing. I love this idea of, thousands of genes, but I'm actually terrified as a microbiologist. I would rather have 10 or 20 or even 50 key genes, and then there's going to be an awful lot of validation we're going to have to do against phenotypic testing, clinical outcomes, and so on. So is there an attempt to have a smaller panel of resistance genes for clinical applications, and is that a way of accelerating the use of these sequencing technologies in the microbiology laboratory?
Yeah, so Dirk has actually done that. It's not 50, it's 350 or something like that. Just looking at the frequency of the various resistance genes in clinical isolates from that sequence genomes from the NCBI. And so we've distilled that, 6,000 genes down to about 350. And of course, it could be very bespoke. You could make this, very local, as Brody said, we don't necessarily have to worry about some of the resistance genes in Prince Edward Island and here in Hamilton, maybe not. So you could make this very bespoke, and we're working very hard to be able to automate this, and I think this is one of Dirk's company's goals is to be able to actually make this cost effective. Certainly, though, I'm sure we're all aware in private hospitals in the U.S., clinical isolates are routinely sequenced now, and linking those genome sequences to an antibiogram that is of natural resistance phenotype and clinical failure is the other big gap, as you pointed out, to see whether or not only is, Brody made a good point, is the antibiogram worth doing? Well, is its genome sequence, but the presence of resistance gene does not necessarily mean phenotypic resistance and clinical failure. So those are big research gaps that have to be covered to make this routine. So yeah, full marks to you, Merritt, for pointing that out.
Thanks, Gerry. There's a question from Rubiet. Rubiet, I unmuted you. Go ahead.
Okay. Thank you, Brody and Gerry. Wonderful presentations. So I have a question to Gerry, but before that, I just want to thank you and Andrew's team and Greg, actually. So I've been in metagenomics research, for over a decade now, and I know about bait capture method, but I have never been so excited about this technology in the past, actually. The reason now is mainly the cost, from the commercial sources of the bait. So it was never cost effective for me to plan for that. So, but thanks to your work and thanks for the database. I'm actually, Gerry, I haven't yet met you. I'm a relatively new faculty at McMaster, but we have already started doing some work with Andrew, mainly on the clinical application side of this technology. So, but my question, I'm just curious to know about the CARS database and the bait set that your teams have developed, right? So, what I think is that there is like the new AMR mechanisms are always emerging, and especially in the settings where there is so much irrational, inappropriate use of antimicrobials. And eventually we have seen many evidence, like, a lot of mechanisms developed in South Asian countries or African countries and eventually became a worldwide concern. So what would be what is your process like, for like routinely updating the database and the bait sets, as well as potentially are you involved in any research to actually discover novel mechanisms, especially in the settings where indiscriminate use of antimicrobials?
So yeah, we're approaching time, so I'll keep my answer very short. The short answer is the CARD database is curated. Andrew has an army of curators who scour the literature. One of the things about CARD is that we don't put a resistance gene in there unless there's a actual publication that we can verify is a real resistance gene. The other way to add things to CARD is to actually contact the CARD database itself. There's an email on there that says, I want to add my gene and here's the data that shows that it's real. I'm not aware of any systematic efforts to do this in lower and middle income countries where there's a lot of rampant antibiotic use, but certainly, labs like ours are constantly looking for new resistance genes in environmental samples in particular, and we're always adding them to CARD. So there's an ongoing effort. If you're interested in doing this, contact Andrew and get yourself into the queue. I think we want to make this the absolute most robust database that has ever existed on the planet.
Thank you so much.
Channeling the
totally agree.
Great. Well, we're at time, so thank you both again for these super interesting talks and great discussion. And we will see everybody next month for the April edition.